On behalf of the Siburt Institute Chaplains Fellowship, let me welcome you to today's Lunch and Learn session. I'm Paul Riddle. I'm the Director of Spiritual Care for Lifeline Chaplaincy in Houston, and I serve as the chair of the steering committee that oversees the Chaplains Fellowship. And Renee Paul is providing our technical support today, and our presenter is Ben Wiles. And Ben just joined our steering committee not long ago and is going to be sharing some thoughts with us today about rural chaplaincy. I do want to put one plug in before we go any farther, and that is that we do have an opening for a presenter at our next Lunch and Learn session, which will be on July 10th. And so if you're interested, if you have something that you've worked up, or if you would like to prepare something to serve as a presenter, just let either me or Renee know, and we would be happy to work you in. Our October Lunch and Learn session, our presenter will be Adam Metz, and he will be speaking about providing spiritual care in an increasingly secular world. So that's coming up in October. So again, welcome everyone. Today's session is being recorded, and so please be aware of that. And without any further ado, I'm going to turn it over to you, Ben.
Thank you, Paul. Thank you for the opportunity to be here. I apologize for the connectivity issues that arose as I was trying to get hooked up here. Just a bit of background on me. I served for about 7.5 years as the chaplain for the East Regional Hospitals for the St. Thomas system in Ascension in rural Middle Tennessee. And that's the context that I'm going to be describing today. But starting this past Monday, I took a new position as the manager of spiritual care for Mercy Jefferson Hospital in Festus, Missouri. So one of the things I'm doing this week is learning how all of their new internet systems work. And apparently some are going better than others. Right now, my hope is that you should be seeing a rolling hillside.
Yes.
With spiritual care in rural settings. You're seeing all that?
Yes, sir.
Oh, already. Good deal.
There we go.
Okay. All righty. Well, so what we'll be talking about today is in rural settings, thinking primarily about hospitals, but also thinking more generally in terms of the kinds of areas tend to bring to their lives, and how we as chaplains and as spiritual caregivers can respond to that effectively. As I said, the primary context I'll be describing will be my 7.5 years in rural Middle Tennessee. My hope is that some of what we talk about will be generalizable across contexts. The first thing I want to show you, though, is this map. The hospitals that I served are marked there, and we'll look at them one by one. But the primary thing to notice, just for definitional purposes, is where they are. Woodbury, Smithville, McMinnville, Sparta, Carthage, Hartsville, Gallatin, Centerville, Waverly. And just how far they are from the Nashville city center. And the kind of care desert that rural healthcare tends to be. There are the place I used to serve back in McMinnville, Tennessee was I think ranked fourth in the country for fewest primary care physicians per resident. It was there's just not a lot available to folks. Um, and when you're serving in this kind of a context, you're dealing with a lot of those care desert kind of issues. So here's just a rundown of the various places. The primary hospital that I served at was Ascension St. Thomas River Park in McMinnville. It has a 28 bed med surg unit, a 10 bed inpatient rehab. Average day in the ER was 75 patients. They had an 8 bed ICU, averaged 500 baby deliveries per year. And they also did some same day and outpatient surgery and had about 250 people who worked there. At St. Thomas Highlands, which was in Sparta, they had a 12 bed med surg and a 14 bed geriatric behavioral health unit. Their ER saw 45 patients a day. They also did some same day and outpatient surgery, and they averaged around 125 staff. St. Thomas DeKalb in Smithville, 14 bed med surg, 25 patients in the ER, a few more surgical procedures, and there about 100 people worked there. And then it's Ascension St. Thomas Stones River, that was in Woodbury. They had a 12 bed med surg. That was primarily a behavioral health hospital. 20 beds of geriatric psych, and then 6 beds of adult behavioral health. 15 patients a day in the ER and about 75 staff. At St. Thomas Hickman, which was in Centerville, Tennessee, this was a critical access hospital, meaning that it was even more of a care desert than other places, and they got special reimbursement rates just to keep the doors open. They averaged 10 to 15 ER visits a day. They also had a home health unit, a med surg floor, and a community outpatient clinic. And they had about 100 people that worked there. And then at St. Thomas Three Rivers in Waverly, they had 25 med surg beds and an ED and about 125 staff. Then a couple of years ago, St. Thomas added some facilities as part of a joint venture with one of the local healthcare networks. And this merger created a place called High Point Health in Gallatin. Now we're about 45 minutes northeast of Nashville. They have 120 medical beds, a geriatric floor, 18 ICU beds, 800 baby deliveries a year, and an ED that included a level 3 trauma center. They have average about 1,000 staff. High Point Health also includes High Point Riverview in Carthage, which was also a critical access hospital with 20 med surg and 2 ICU beds. They have an OB unit that delivers about 75 babies a year, plus an emergency department, and they have about 70 staff, and most of their day shift staff fits into that picture there. And then High Point Health Trousdale, which is in Hartsville, Tennessee, about 45 to 50 minutes east of Nashville. It's another critical access hospital. Most of what they do there is swing beds. They have an emergency department, but they have about 50 people who work there. One of the things about these hospitals, though, is the kinds of diagnoses that bring people into their care. These are the primary what I've listed are the 7 most common diagnoses in the rural hospitals where I served. Congestive heart failure, COPD, pneumonia, or the kind of after effects of once having had COVID that it wreaks on people's lungs long term. Diabetes was a big thing. Anxiety and depression and behavioral health issues were a significant concern for our folks. Chronic kidney disease, falls and failure to thrive. What these what these diagnoses all have in common is a couple of things. One is that the acuity level does not tend to be very high. Um, in a lot of our rural hospitals, if you experience a level 1 trauma, like you're in a car accident that breaks multiple bones, you suffer a gunshot wound, you lapse into a coma all of a sudden, odds are you're probably not coming to Smithville, Tennessee. If you have a significant trauma, you're probably going to a trauma center, and that has definite advantages for the patient because they can get the care they need. But it also creates a situation for the hospitals where the kinds of patients that they see aren't the ones having those significant traumatic major life altering events where they were going about their business and then all of a sudden something terrible happens and now they're in the hospital. So it's not the kind of facility, these aren't the kinds of facilities, these aren't the kinds of places, generally speaking, where the significant difficult traumas and those high acuity type events are going to lead the person to be a patient in the hospital. Similarly, if the condition you're dealing with is rare, if you're one of 6 people in the world who has had a particular illness in the last 10 years, you're probably going to need a specialized level of care that isn't going to be available at a place like Sparta, Tennessee, or Centerville. You're probably going to need to be in a place that has more specialists, a place that has more infrastructure, a place that has more resources, and when those kinds of rare illnesses arise, there isn't the to put it in economic terms, there isn't really the demand to justify the supply. Every hospital doesn't need an organ transplant center. So if you need a heart transplant, you're probably going, if you're in Tennessee and you need a heart transplant, you're probably going to St. Thomas, Nashville, not St. Thomas, Woodbury. The third pattern in all of this is, I don't know if you noticed this, but congestive heart failure, COPD, anxiety and depression, diabetes, these all tend to be illnesses that bring you to the hospital, not because, as I said, you were suddenly fine, you were going about your life fine, and suddenly something bad happens. A lot of these illnesses are the kinds of things where the issue is management, not immediate acute crisis. These are the kinds of illnesses where when you get sick enough to come to the hospital, it's often because you had difficulty managing things at home. We did a project at River Park about 5-6 years ago now, where we were looking at congestive heart failure patients and why they kept being readmitted. And the issue that some of the issues that we found with readmission was that when somebody gets a CHF diagnosis, somebody somewhere just got a full-time job. The patient has to be weighed every day. Their food intake has to be monitored. They have to be, there's medication that has to get involved. And even in a lot of cases, even with proper management, it's not often realistic to think that a person is going to be able to stay out of the hospital for more than 60 to 90 days at a stretch. The issue we were having is that people were being discharged with a CHF diagnosis and coming back in 6 days. And so our project was to work on how to help people manage at home, help people bring resources bring resources to bear for these patients to help them manage things at home, help them stay at home longer, so that rather we didn't realistically think we were going to be able to prevent the person from ever having to come back to the hospital. So the goal was let's have them be home for as long as they can. And a lot of times when you're dealing with diagnoses that are more on the management side than on the curative side, that's really the task. It's just how do we set these folks up to be able to stay home as much as they can, as long as they can. Some of the barriers that we come across when we think about managing these chronic illnesses and helping people stay home from the hospital. One of the big barriers is poverty. Medicine's expensive, and maybe you have insurance, maybe you don't. And if you don't have insurance, somebody's got to pay for that medicine. And maybe you can afford to pay for your medicine this week, and maybe you can't. Maybe the rent's due. Maybe you want to eat something. And when your doctor is telling you you have diabetes, so you have to take your diabetes medicine, you have to have your diabetes supplies, you have to check your blood sugar every so often, you have to do this, you have to do this, you have to do this. And it becomes financially overwhelming, if nothing else. There's also the issue of education. A lot of times when people find out that they have one of these diagnoses that is going to require them to manage things in the long term, maybe they understand what we're telling them and maybe they don't. Maybe they have an education level that allows them to make sense of the kind of medical jargon that people who work in hospitals all the time hear every day, or maybe they don't have that level of education. I know, at least in my case, I say I'm reasonably well educated, but it took me a while to learn what all the letters stood for. It took me a while to learn what the letters NPO stood for, what the letters PRN stood for, what the letters, what BID versus TID was. And there's a lot of that medical jargon that just flies over people's head. And when you're in a situation where you didn't get a great education to start with, and now people who are highly educated are speaking to you in their language instead of your language, then just understanding what's happening with you can become difficult. There's also the factor of the care desert. I mentioned about primary care docs in Warren County, Tennessee. A lot of people who live in rural areas live in places where there isn't necessarily a hospital right around the corner. A lot of the patients that we used to get at River Park McMinnville would come 30, 45 minutes to the hospital, over the river and through the woods, sometimes literally. And if you've got 3 primary care doctors trying to serve a county of 12,000 people, then you've got to hope they have an appointment for you. Hope that your schedule and the doctor's schedule lines up so that you can see them. And then if you don't, then you're getting back in the car and driving some more. And it can become difficult to manage a chronic condition in a setting where there just aren't enough doctors and other kinds of facilities to go around. Think the example that frequently comes to mind for me is dentists. We have probably all heard about the importance of regular teeth cleanings and regular checkups and regular this and regular that and regular the other things. You just have to hope that there's a dentist who's in your area and available to do that. That's not something that rural areas can really take for granted the way you would in an urban or suburban setting. Um, so some of the barriers to management are somewhat external, and some of them are internal. Lifestyle choices people make. Um, it's not it's not realistic, and I don't even think it's really fair to ask people to make maintaining their physical health the only consideration in whether or not they do a thing they enjoy. Um, and sometimes those lifestyle choices can have health impacts. I will I will hope this is a safe space. I acknowledge this is being recorded, so I hope this doesn't get back to my cardiologist. But for me, bologna sandwiches are comfort food. There are times in my life where psychologically I needed a bologna sandwich to get through the day. It's bad for my heart. It's bad for my liver. It's bad for everything from the neck down. But it's a lifestyle choice. And there are times when I make that kind of a choice on purpose because I feel like I know what I need. And there are other kinds of things that people make choices about where those lifestyle choices will end up making managing a chronic health condition difficult. There are also political choices that they make. I will leave to your imagination and to y'all's experiences what that might look like. I will merely name the one thing that where can create a barrier to management is there are a lot of places where people will vote for candidates who will deny them Medicaid benefits. And rather than jump down that rabbit hole, I will merely name its existence and move on. And some of the barriers to management comes out of the dilemma of making good choices versus having good choices. In order, I'll again using myself as an example. There was a time about 3 or 4 years ago, where I had to be admitted to the hospital overnight for observation. And because I'm a heart patient, the nurse came in and started talk and gave me the lecture of all the things I needed to stop eating and all the things I needed to start eating. And I will acknowledge that a lot of what I eat is under my control. It is up to me what I eat, when I eat, whether I eat, all that. There was also the factor that at the time I was doing a job where I had to drive 30 to 45 minutes between hospitals several days a week. And in order for me to eat lunch, I had one hand on the food, the other hand on the steering wheel of my car. That can make salad tricky. So it was a situation where I was trying to make the best choices that were available to me, but recognizing that just because it's healthy for you doesn't necessarily mean it's on your menu of options. And there are a lot of folks in rural areas who find themselves in similar situations. The choices we might want them to make might simply not be available to them. So that's how rural healthcare is different, and rural ministry. Whether you're working in a hospital, whether you're dealing with sick people or not, rural ministry has its own dynamic at work there also. And the lights in my office just turned off. Excuse me. Oh, there we go. Sorry, new office. Apparently, it wants me to move occasionally. There are some areas of rural life and rural healthcare that are a bit unique to that setting. There are some, and I want to couch this in terms. I don't want to make it seem like rural is all bad, because there are some significant areas of spiritual strength in rural areas that you might not experience in urban or suburban areas. And one of those areas of spiritual strength is around connection. When I was working in McMinnville, the nurse manager for the med surg unit at River Park Hospital was also the mayor. Um, what when when people would come into the hospital, oftentimes they might be a room or two down from somebody they go to church with. Family connections are very strong in rural areas, or they tend to be. Um, Church connections, just the necessary interconnectedness of people is a significant asset, in a lot of rural areas and rural communities. One of the things I look for, when I'm trying to understand the culture of a place, is how tight knit is it. Um, on the one hand, a tight knit community can be a difficult place to break into if you're coming in from the outside. But on the other hand, it can also be a significant asset, a significant point of strength, when something comes up or a need arises, or a situation comes about that requires the community to band together. A lot of those connections and a lot of that together bandedness is already in place. That was when talking about that project about helping keep congestive heart failure patients out of the hospital for longer stretches. One of the ways that we were able to do that, and one of the assets we were able to leverage, was the fact that when I called a couple of local ministers to come to the hospital to help be a part of this project, they were able to bring not just themselves, but they came basically representing networks, pre-existing connectedness, church to church to church, so that whatever the need was, if I didn't know who could fill it, I knew who knew. And that sense of interconnectedness and connection in rural areas can be a real asset. Likewise, tradition. Rural communities are what they are in large measure on purpose, and rural communities are what they are in large measure because that's what they've always been. I'm making air quotes for those listening to the recording. The traditions of a place, the fact that there are people who have lived in the same place for nigh unto ever. The fact that there are families that might have gone 6 generations without crossing the county line. The customs and the traditions, that define these communities really do bind them together in ways that can be a real asset to their spiritual strength. They have customs that they can rely on. They have things they can count on always being there and always being in place for them. And those traditions can really be formative of these communities. Likewise, one of the things I've observed, and this may be more stereotyping than anything, but rural communities the rural communities that I've experienced seem to have deeper feelings of awareness of providence and transcendence. As an example, when I was back in Tennessee, my primary area of service was 4 counties. Warren White, DeKalb, and Cannon counties. Those four counties only had about 50,000 or so people in them combined, but there were over 500 churches. Warren County alone, there were 168 churches in a county of 12,000 people. Church and God and connection to that which is providential, connection to that which is transcendent, is in a lot of these rural communities culturally defining. At least it was in Tennessee. At least it was in the Bible Belt section of rural. I can't promise that the same thing would be true in North Dakota. I certainly wouldn't say that as strongly about a place like rural Minnesota, where I spent a couple of years about 20 years ago. But even still, compared to similarly situated urban and suburban areas, rural communities tend to have a stronger sense of that which is providential, that which is transcendent, that which is power higher than themselves. There are also areas of spiritual struggle that are more potent in rural areas than in others. One of those is a Russian word I came across. And if you're into 19th century Russian literature, one, welcome to my soapbox. I'm sure there's room for another person up here. And two, one of the key concepts that comes out of that era is the concept of poshlost. And it's not a word that translates very clearly into English, but the general idea is that there's an inevitable spiritual decay that arises from self-satisfied mediocrity. Once a person or a group or an entity decides that the cost of doing better is greater than the benefit I would get from doing better, then a decision is made to settle for mediocre. And what writers like Nikolai Gogol and Vladimir Nabokov observed is that when that decision is made, there is an inevitable spiritual decay process that begins. And eventually, whatever entity or institution it is that has landed itself on self-satisfied mediocrity will eventually wither away and die. And a lot of times in a lot of places, it's one of the reasons why so many communities stay as small as they are. And in a lot of family systems and in a lot of church systems and in a lot of governmental systems even, it's why it's a lot of the reason why the struggles are what they are. It's that the decision has been made that those in power benefit more from the mediocre status quo than paying the price of getting better. And once that choice is made, that's just pretty much the ball game. Spiritual decay becomes inevitable at that point. Another area of spiritual struggle in rural areas is what I call overwhelming imminence. It's where, especially if you're of a mindset where I want to just go about my life and hope nothing happens. When something does happen, it can be very overwhelming. If you don't have the resiliency reserves and you don't have the spiritual resources in place to deal with things as they arise, when they do, it can be a lot. It might not be a lot in the grand scheme of things, but it's a lot to you. If you're 5 feet tall, it only takes 7 feet of water to wash you away. And it doesn't matter how much deeper the water gets than that. It doesn't matter how hard you might be able to swim. It's just when it's more than when the current is more than you can stand up in, you're going to be washed away. And for a lot of folks in rural areas, difficult circumstances can get very overwhelming very quickly. There's also binary thinking, and what I call polar codependency. One of the areas that of struggle, particularly when patients come to our emergency rooms, is you ask them what their pain is on a scale of 1 to 10, and they have no idea what you mean. Or they might just, or they ask them, scale of 1 to 10, how bad are you hurting right now? And all they really understand is I'm hurting. So they pick a number. They might say 5, and the nurse might say, okay, I'm going to give you a medication that's going to lower the pain level from 5 to 2. And the question, they come back 30 minutes later is, well, did the medicine work? Well, if I'm still hurting, no. They are either in pain or they're not. Similarly, polarized thinking, where things are either great or terrible, and there's not a lot of in between. And there is a tendency to take thoughts and perspectives to their extremes. And again, particularly in a situation that is overwhelming. So rural hospital chaplaincy is different from chaplaincy in other types of places, because a lot of what we do is influenced by the fact that we're in the kind of community that we're in. When you're doing rural hospital chaplaincy, you really want to try to accentuate the strengths. That means you're going to be doing heavy doses of staff care, particularly if you're in a behavioral health setting. A good portion of the care you're going to be providing is going to be to the people who are themselves the caregivers. I remember about 4 years ago, the Delta wave hadn't hit yet from COVID. Vaccination was just starting. And there was a day where on my med-surg floor at River Park, there were 19 patients there, and 6 of them were hospitalized because they had overworked themselves taking care of somebody else, and now they were sick. So a lot of what we do in hospital chaplaincy in rural settings is heavy doses of care for caregivers, making sure that trying to help those frontline people, whether they're the nurse on the floor, whether they're the home health aide that's going out to people's houses, whether they're the younger relative caring for the elderly relative, providing support to them so that they can continue to provide the support to others that they like, that they're called to. Second thing is, don't expect to change too much too quickly. Tradition is a thing. It's a thing on purpose. It is a strength of these communities. And when you're in a rural setting, it's not realistic to expect too much to change. Too much to change too quickly. Oops. Thirdly, engage church and community resources. Spiritual care of a rural community is a team effort. Everybody who could conceivably come under the roof of your hospital is to some extent a member of your congregation. So part of the job of a chaplain in a rural hospital is to be purposeful and intentional about engaging with church resources, engaging with community resources. Take advantage of the fact that there are all of these folks who are there and ready and willing to serve. And the fourth thing is, let yourself be loved and cared for. one of the stories from very early in my time at Ascension was I was driving between Sparta and Smithville, and about halfway there, I became completely overwhelmed with food poisoning, and I drove myself to drove myself the rest of the way to DeKalb Hospital and checked myself into the ER, because bad things were happening, and I don't want to get into all the gory details, but I suddenly showed up when I was a patient. Um, I got more positive feedback from that than from most of the actual care that I gave in my first year as a chaplain, because I found myself in a situation where I needed them to take care of me. And when I let them, the fact that I let them do that, the fact that I trusted them to take me in that kind of a setting, really did a lot for that kind of for that sense of connectedness, that relationship building. Now, I don't recommend the food poisoning. That was not pleasant. That was not good for anybody. But if you find yourself in a circumstance where you can let people love on you, let people take care of you in the way that fits what they do and how they function, that'll go a long way toward accentuating the strengths of the community. Similarly, addressing the struggles. Again, heavy doses of care for caregivers. Those are the folks who are providing a lot of the care that's going to happen for your patients. There's a lot that is outside the scope of a chaplain's service. One of the things they used to say at River Park is that if it has more moving parts than a pickle jar, Chaplain Ben will find a way to break it. So if so, make sure you stay in your lane, but also make sure that what you're doing is being supportive of the people who are doing the things that they need to be doing. Addressing the struggles means heavy doses of care for caregivers. It also means we're the ones who we're the ones who walk into a room and where we might be the only person in the room who knows everything's going to be okay. Our role as spiritual caregivers, especially in rural settings, is to be the one who has the proper perspective on the present circumstances. We're not overwhelmed. We're not underwhelmed. We are properly whelmed. One of the skills that we bring as chaplains, especially, is the ability to have that perspective, that the ability to recognize that you are having the worst day of your life right now, but it's still Tuesday. And tomorrow will still be Wednesday. And I'm going to help you manage this moment and get you through this difficult time right now. And I'm going to acknowledge the difficulty of the situation you're in right now, but I'm also going to acknowledge the reality that we are also all going to walk out of this room at some point. Third thing to address the struggles in rural chaplaincy is to learn all you can about palliative care and behavioral health. There might not be a lot of the services available that you would want, but the more you know, the more you as a chaplain can know and understand about how chronic illness works, how palliative care works, how behavioral health works, the better equipped you will be to meet the needs that you're likely to come across. And then the fourth thing is knowing and enforcing your own boundaries. Spiritual care in a rural area is a lot. It can be overwhelming at times. There will always be more to do than there is you to do it with. So knowing where your lane is, knowing what your own boundaries are, knowing what you are and aren't capable of, taking care of yourself, making sure that there is a you to play the role on the team that you've been given, that you've been called to. Just knowing and enforcing your own boundaries. It is spiritual care of a rural community is a team effort, which means it's not all on you. Some of your teammates may be better or worse at their jobs than you might like, but there it's still on it. Your role is your role, and knowing what that is and being able to enforce your boundaries and be what you're capable of and let others be what they're capable of is going to be a key component in addressing some of the struggles that arise in rural areas. So thank you for your time today. I've enjoyed making this presentation and talking about some of what rural chaplaincy is and how it works. I think we've got some time for. I hope I've left enough time for questions and conversations, and we can talk about this together.
Ben, I want to thank you for your presentation, especially the perspective on for the kind of some of the unique dynamics of rural communities. Um, those of us who are city dwellers can sometimes either have forgotten about that or uh, be less aware of it than we could be, and that I found that to be very helpful.
Thank you. Thank you. Yeah. I have, yeah, the number of people who were just amazed that when I lived in McMinnville, Tennessee, the nearest Chick-fil-A was 45 minutes away. I've got several city dwelling friends who like, how can you live 45 minutes from Chick-fil-A? Yeah, So yeah, I can appreciate some of the perspective differences in urban versus suburban versus rural. Yes, go ahead.
Ben, I appreciate your presentation. That was really, I'm in the Detroit metro area, and so hearing about this is a really fascinating topic. I wanted to ask you a question about how you navigate being both a spiritual care provider, but also when you were a member of kind of a tight-knit rural community where I'm imagining that dual relationships are kind of inevitable. Did that ever become a dynamic that you had to kind of navigate?
Um, part of the dynamic there was that I was there for 7.5 years, which is simultaneously from the perspective of a ministry career a long time, but from the perspective of a rural community, not really. So part of that dual role was there was a sense in which you sort of had to embrace being recognized at Walmart. There were times when I would go to a funeral and someone would come up to me after the funeral and talk about the time I visited somebody that the funeral wasn't for, in the hospital, and I saw 2,000 patients a year. I mean, I don't really remember all of them. Sorry. Um, but yeah, simultaneously being a member of the community and a spiritual caregiver for the community. Yeah, it's a bit of there's a bit of a dynamic there, and part of it for me would again goes back to that letting them take care of me when that was what was appropriate. Um, being being a good customer for the handyman. Um, being being someone who also had needs and was vulnerable and wasn't immune to the pressures and and the concerns that arise from the fact that you live 45 minutes from Chick-fil-A. And being an appropriate level of open and vulnerable, with the mindset of I'm ministering to this community, not just to this hospital. And at the same time, there are times when I need to not be your minister. I need to eat a bologna sandwich. So yeah, there were times when there was some navigation, and frankly, it's something I embraced, but I also recognize that not everybody would. That there's a certain personality, demeanor, skill set that some people might or might not possess that would make a rural setting a better or worse fit for them personally.
No, I appreciate that. I work in a level 1 trauma center in Ann Arbor, and in 5 years, I can't say that I've ever run into anybody I've seen in the hospital in any other place other than the hospital again. I haven't run into anybody at Walmart, so to speak. And so I was thinking about, keeping boundaries and how to navigate some of the requests for like doing funeral care or postmortem care. It's a little bit easier here because I just say, I restrict my ministry to the hospital. But in a rural setting, I would imagine those boundaries are maybe a little more blurry, so to speak. Yeah. So interesting.
Yeah, they're blurry, and they, to some extent, they kind of have to be, partly for care desert reasons, but also just because if these are rural people, if they are going to accept you as their chaplain when they're in the hospital, it's going to be to some degree because they feel a connection to you outside it. And I don't know if I'd use the word advantage to describe being situated in a level 1 trauma center, because that is its own kind of bonkers. I did my residency at one, but there's a clearer opportunity to bound your ministry to the walls and roof of the hospital. Yes, Rudy, you have your hand up.
Yeah, I got it. There you go. Thank you.
Yes, go ahead.
Thank you for the share. Thank you for your lesson. At first I was kind of like, okay, where we're going with this, and then I started getting there because I'm in the suburban area. I'm in the city, right? So like, I don't think about importance. So I start thinking, what if God took me one day to a rural area? Like, you got to start thinking more beyond the box you're in, and so I appreciate that. So as far as you were talking about this idea of because it's a close-knit community, obviously running into parishioners or even like just people in the hospital setting, right? And one thing that they teach us in our UNF CPE, even if you go in there and you know them, don't act like you know them to a degree. And it's kind of tough because, like, well, if I do know you, I want to say hi. But I understand how it can get in the way of the spiritual care process, But I'm just curious, how does I'm assuming that you were commissioned by the Siburt Institute and the Churches of Christ. So how does the Stone Camel restoration movement? I'm just curious, like to hear, how does that inform your chaplaincy, knowing our tradition, where we come from, and how do you approach how do you use it to approach patient care?
Well, for me personally, I grew up in Churches of Christ. I was a congregational preacher for about 20 years. And so I speak the language natively. And there is a sense in which, and one of the advantages I had in Warren County, there were 168 churches, 37 of them were Churches of Christ, which nationally writ large is mind-boggling. Just how closely tied that community was to our tradition and history. So there were times, especially early on, when it became a bit of a crutch. But but there are also ways in which it became an asset. Um, the idea of individuals within community, the idea of that simultaneous personal responsibility for oneself, but also that sense of shared responsibility for one another. I think that really resonated within my approach to ministry, particularly when it came to some of those care desert issues. Does that help? Was there something specific I can
Well, no, I
speak
just
to?
I just would like to say, like for me, like like one of the challenges with being, a Christian in chaplaincy, obviously, we have to be interfaith, right? That's a challenge. And for me, it's like, how do we, and because I've seen and experienced, many chaplains, and this may be a topic for another day. Who knows? Maybe I could do the next teaching. Who knows? But I think it's very important in our chaplaincy. For me, I'll speak for myself. Like I guess I'm new to this, and so I've been here for about the last two meetings. I'm new to chaplaincy. I was 27 years as a Navy veteran, as a mechanic, and so I'm learning. I'm learning from everybody. I'm in my second unit of CPE, so I'm learning. And so what I just want to know is glean the knowledge from everybody's experience, but also, my fear is this. Like my fear is, just being honest. I want to keep my identity in Christ, but at the same time, I also have to operate in the interfaith world, and I'm learning how to do that through CPE. But I just like to know from your experiences, because you guys have been chaplains for much longer than I have. How does that look like in your everyday life to be a follower at the same time, have to serve in an interfaith community, which is not impossible. But I'm just curious how that looks.
Okay.
You know what I'm saying?
Yeah, I think so. And I'll offer you this. I see my role as a chaplain as I want to help you be the best version of you that you can be. And it's not my job to tell you what that is. I can facilitate exploration. I can facilitate conversation. But ultimately, whatever formation God is working in your life, He's working in your life.
Yeah.
And so, like even in a rural setting, I talk about 37 churches of Christ in Warren County. That leaves 131 that aren't. And it's not my it's not my job to turn them all into heaven forbid versions of me, because one is plenty. But yeah, I think my approach tends to be that God is doing something in your life right now, and whatever I can do to help you become whatever it is you're becoming, that's formative, that's productive, that's whatever synonym for positive you want to use. That I want to help with that, but ultimately at the same time, it's what you're doing is what God is doing with you. God is doing with you.
Yeah. You answered.
Oh, certainly.
You answered. Yeah, that was pretty much. That's a great explanation. It's very simple, and that's why I was kind of like,
okay,
I'm kind of into your perspective too. So thank you for that. That's really helpful.
Certainly. David.
Thanks for answering that question. I've been a chaplain both in a metro area, and I've been here in Stephenville, Texas, which is a rural hospital of the Texas health system. And one of the things I found that was consistent with both is dealing with people returning to emergency. They'll get out, they'll go back. But it seems different in a rural setting that you don't have the resources. They're depending on ER to be their medical care. So you have a lot of that return. And it also seems that there's more desire for the chaplain to be engaged in trying to help cut down on that return. Mm-hmm. Is that your experience, Ben?
You're singing Kim Scully's song. My lead quality nurse at Ascension, that was the song she sang. That was what sparked the project around congestive heart failure in the first place, was the fact that people weren't able to manage things at home and they weren't able to stay home. And so because it was a rural community and the primary social support assets were found through churches, the assumption was that if somebody was going to help, it was going to be the churches. And if somebody was going to make the connection between church and hospital, it was going to be the chaplain. So a lot of my work early on was in building out those community relationships and knowing which churches offered things like which churches had food pantries, which churches offered rides to doctor's appointments, which churches helped pay for medicine, and just to try to build out those support relationships. But then there's also the piece of it where the situation that leads to the readmission is more of a social or spiritual determinant of health than it is health itself. Where the reason they keep coming back to the hospital with panic attacks is because they get home, they get lonely, they hear something go bump, they start to hyperventilate. Or they get home, they have a congestive heart failure diagnosis, they weigh themselves, and just to pick a number out of the air, it says 228, and they don't remember if they were supposed to come back to the ER at 223 or 233, so they assume the worst and come back to the ER. So yeah, that's a key component of it, and the spiritual care side of that is one, identifying the internal psychological structures of the person, identifying the family structures of the person, and finding ways to help manage those kinds of resource issues. But two, to try to encourage those people in the community who want to help in productive ways. Things like telling a church that has a food pantry, if you kept certain of these other kinds of things, you could give them to heart patients, and the food in your food pantry that's most shelf-stable is probably also the saltiest. So if you keep something else in your pantry for heart patients, then you can help them, but also help us. So yeah, there's a whole lot more to it than just seeing patients in the patient rooms.
Thank you.
Just want to note that we've gone a little past the top of the hour. I don't know if that's an issue for anybody, but just wanted to note that.
Yeah, I apologize for that. That some of that's my fault for these connection issues early on. There's a comment in the chat. I also think that from Matthew says, I also think that when recidivism and return issues, chaplains can use our skills to help facilitate goals of care conversations. Yes, those goals of care conversations are very important, particularly in rural settings, particularly in settings where patients are, and for lack of a better way to phrase it, hyper aware of the presence of God in their lives. Sometimes have a level of awareness of God's providence that is not as productive as you would otherwise hope. And so helping people come to grips with the fact that yes, it might well be within God's will for you to get sick and die from this. And having those difficult goals of care conversations and be able to bring that theological perspective to them is huge in rural chaplaincy, especially.
Ben, I had someone send me a couple questions.
Yes.
One of them, they were just wondering how much of your care is end of life?
Not a lot. I'm assuming normal times as opposed to COVID Delta wave. But yeah, a lot of the super acute illnesses, like your heart attacks and your strokes and that sort of thing, you're probably not going to end up at a rural hospital if you're having that. So yeah, probably not a lot by most standards, but a lot of the care that would be more proximate to end of life. A lot of the folks that I would see would be maybe 6 months away, 3 months away, in desperate need of palliative care, more so than end of life crisis care.
Yeah, that makes sense. Thank you.
Yep.
And they had one more question. It was about kind of like staff interactions. I know you talked a lot about how you need to work with a lot of staff as the caregivers and things like that.
Mm-hmm.
They're kind of just curious what your interactions with staff are like. If you could go into that a little bit more.
Okay. Yeah. For one thing, they are regular. It's probably probably have one staff interaction for every 2 patient visits. So it's regular. I try to be predictable. I try to follow travel patterns as much as I could, and to intentionally seek out staff. Like even when I first arrived at the building, I'm gonna find a nurse's station and check in. But yeah, just making sure I'm very, very aware of staff needs, be visible for them, and then just making sure that they know that they're not an afterthought.
Yeah.
That I'm their chaplain too, and that I might only be the patient's chaplain for a few days, but I might be a staff member's chaplain for years, and to build that relationship intentionally.
Yeah. Thank you.
Well, Ben, thank you so much for bringing your wisdom and experience to us today, and to everyone for your participation. Are there any final questions or comments? I mentioned at the outset that we had an opening for the July Lunch and Learn, and I just got a message from Matthew Dowling that you have volunteered to be our presenter. Thank you for that. And if you would just, when you get a chance, send Renee and me your topic so that we can get that in the schedule. That would be a big help.
Paul, I emailed Renee already. I didn't have your email address. Maybe she can
Outstanding.
pass it along. And I think
That's
it might
perfect.
complement some of what we were talking about today. I work as a palliative care chaplain in a level 1 trauma center, and I thought it might be good to talk a little bit about goals of care conversations and how to be a spiritual care provider in spaces where very important decisions are being made.
Excellent.
Awesome.
Yeah, that's going to be, I think, a lot of interest in that. Thank you so much for that. Well, if there are no other comments, we've gone a little past the end of the formal end of our hour, but it's been a great conversation and a thanks to everyone. Um, we can go ahead and close out for today. But Ben, thank you so much.
Yes. Thank you all for the opportunity. I enjoyed spending time with you all today.
Yep.
We'll see you in July.
Bye, y'all.